Hi, I'm Dr. Adam Friedman, professor and interim chair of dermatology at GW School of Medicine and Health Sciences. And I'm joined by close friend and colleague, Dr. Yasmin Krikorian, assistant professor of dermatology and interim chief of pediatric dermatology at Children's. We are interim twins. High five. We just literally got out of our session entitled Immunomodulators for Inflammatory and Neoplastic Skin Diseases. It was a great session, and would love to start by asking a few questions about your talk on immunomodulators for pediatric dermatology. So first off, is there anything on label from a systemic immunomodulatory perspective?
Luckily, there are a few things, especially for psoriasis. So etanercept is on label from age 4 onwards. Ustekinumab for teenagers. And then for hidradenitis, we're lucky to have adalimumab on label. We do have a huge population of patients with hidradenitis that we treat. But beyond that, we're really waiting for the trials to come out and excited about what's coming.
Okay, so speaking of mostly off-label, let's go through a couple diseases, and would love to get your insights in terms of how you use different medications, of course, which ones you use, and then what are some practical pearls and clinical considerations when using those medications in little ones. So let's start with atopic dermatitis. You got a complete train wreck coming in head to toe, a mixture of lichenification, oozing, weeping, mom's crying, help me! What is your go-to off-label systemic anti-inflammatory immunomodulator, immunosuppressant? Pick your poison.
Right. Well, I mean, I think what you're saying is, joking about mom saying help me, but really the family is devastated and we're coming in crisis. So that's, I think you've highlighted an important point. The literature on using systemics in children points out it's very important that we first need to optimize our topical therapy, and ironically, often children are not optimized. So parents will say, oh, I already tried that medication, but I think first you need to have it in your own hands, that you try the good old drugs, the topical steroids, the emollients, and show that they fail with you, because I can't tell you how many times that's not the case. Once that's gone, then we kind of look at the literature to look at what other drugs have been used, and the preferred choices based on papers for pediatrics from PD derms have been methotrexate and cyclosporin, are good old drugs. The nice thing about those medications, though they're off-label for use in atopic dermatitis, they do have on-label use in children down to infancy, so that's very reassuring to parents and have been used for many years. Methotrexate is also used chronically in children for arthritis, so we have a lot of literature to draw on when we support our parents, and that's a good medication from that standpoint. But the downside is that I don't feel that it's often very effective, a true slam dunk for parents, and that does require blood draws and monitoring and so forth. So that is something to keep in mind. Cyclosporin I'm using more now because of its rapid onset of efficacy as a bridge to what I think will be the new era of treatment of eczema medications that are now off-label, but in clinical trials like dupilumab.
Great. I mean, obviously psoriasis, we do have some options. If you weren't to go with those options, what would be your first line for a more moderate to severe psoriatic child?
Yeah, so that plays into the pragmatic question, like what can I get covered? So methotrexate I think still has an important role to play, though off-label for psoriasis. It's inexpensive, has a long history, and can work quite well. But then from there we'll go to drugs usually like etanercept that are FDA approved down to the younger ages, or ustekinumab in our older children. The nice thing about ustekinumab, if you can get it, is it's infrequent dosing, so you're not having kids have shots as often. So I look forward to the clinical trials coming out, to the younger approvals with the 6 to 12 that are in clinical trials, because that may get us that nice option for the kids.
Sure. And last but not least, hidradenitis suppurativa. And truth be told, if you're getting them in your clinic and as a PD derm, that's fantastic, because I think this is something that's missed for years. We know the data shows that the time of onset to time of diagnosis is often 7 to 10 years. So an adolescent is often an adult by the time they maybe get to me or someone else. So when that person does get to you, one, are they usually more severe or more early in disease? And two, what do you do about it?
Yeah, it's interesting. We have a tremendous number of adolescents, even down to like tweens, the 12-year-olds that with hidradenitis in Washington, D.C. So I think it's underappreciated that this is a disease of teenage years. We get any realm of it. So you may get your very mild, where it's a comedonal almost appearance, so-called acne inversa, to the horrifically severe. So I think your point is well taken that we should treat them aggressively and probably even move the needle back to treating the earlier stages more aggressively. We do have adalimumab that is on label for treatment of these children, and we do use that quite a bit, as well as optimizing, of course, lifestyle modification, using antibiotics, and so forth. But I don't feel that, still feel we have a conundrum where it's you wait till they're severe to use the adalimumab, whereas it's probably effective to use it earlier on, and I'd like people to push that literature forward where we'll feel comfortable telling someone who's maybe mild to moderate, no, we want to use this drug as a preventative. I don't know that I'm yet comfortable doing that.
Sure. I mean, what I'm hearing from you is really we got to go strong or go home. tone when it comes to these patients, that simply handing off a topical antibiotic for a even mild disease patient is probably unacceptable. It's interesting, the recent recommendations came out of Europe looking at the literature and where the evidence is, and while I personally disagree with those recommendations, starting simple and low and working way up, as adalimumab is third line, it's based on the literature, so I don't blame them. I blame the fact that we have limited evidence, but you can see in PubMed there are innumerable papers coming out, so we certainly need more of it. Now, thinking about your life is cruel patients who have multiple comorbidities, you mentioned you had a couple examples in your talk which were phenomenal. Can you share how you approach those types of patients that have numerous things going on where your standard approach really can't be utilized?
Right. So for one example I gave was a person with multiple sclerosis who also had hidradenitis, limiting our ability to use TNF-alpha agents because of the risk of demyelination. I think that's where the other specialty drives the train, to the extent that you look at, okay, I can't use these drugs, and then you're checking in with their, whether it be neurologist or pediatric gastroenterologist or what have you, you end up then running it by them, but more often than not, they look to you for guidance. So then I'm looking at the literature and saying, I'm going to present you with X, Y, and Z options. What is okay for this kid? And then we drive the train. So I think that is important, and that's when you do get into this kind of tertiary care. I think that should be kind of maybe owned in the academic centers where they're so complex. But it is important to remember those exceptions help us to actually maybe writing them up to show that these drugs are safe in children. So off-label use sometimes is our only choice, and we should write those cases up so that we show that there is a safety record until it comes out as a trial.
Sure. Anything else I'm missing? Anything else you want to add?
No, I think you did a great job. I mean, I think my main thing is that children sometimes require systemic treatment, and we shouldn't hold it back from them because of their age. If they're severely ill and they need to be treated. I think that's well accepted in fields like rheumatology or inflammatory bowel disease in children, and somehow not as accepted in pediatric skin diseases, where we'll see kids getting treated with topical steroids for horrific morphia. So I think that if a child has a severe disease, they have a severe disease and deserve treatment just like an adult would.
So thanks for joining us. Hope that was informative and will be impactful for your clinical practice.